Hey there, everyone. Let's continue our conversation looking at GI conditions. We're starting out with another serious one in this part, colorectal carcinoma. The incidence on here I think is notable. It skews older, men more than women, and factors such as a history of obesity and smoking, they're right up there when we're talking about risk. So this one's pretty lethal. It accounts for approximately 15% of all cancer-related deaths in the US. Looking at these metrics as I was reviewing these slides and updating them, it occurred to me how much we don't talk about cancers of the GI tract, and yet how incredibly common they are. So let's think about how these things tend to happen. Well, with your risk factors, again, there's obesity and smoking, but other conditions such as inflammatory bowel diseases, diets low in fiber, diets high in saturated fats, and diets with little to no vegetable intake, there we go. That's plenty of folks, right? So if you're an older person who's been eating in this risk factor diet profile, the risk is non-zero for these individuals. So early diagnosis is really important when we're talking about colorectal carcinoma, and that's why I have a slide here on this with a little fiber image. Increasing your fiber, fruit, and vegetable intake while decreasing your fat intake, that's huge. It lowers your risk. It's that simple. And it's really important, I think. What's interesting is that if you decrease your total calorie intake by a quarter of what you're taking in, you decrease your risk of colorectal carcinoma by over 50%. So I really think that that's about is decreasing high calorie rich foods, okay? That's really what's doing it, rather than the total calories really, right? It's more that perhaps a person takes in 2,000 calories a day and that's considered typical. For individuals who are eating in the high-risk diet, they're probably taking in 2,500 to 3,000, right? So that's really what we're worried about there, rather than, we're not talking about the power lifter who takes in a ton of protein to maintain muscle mass. That's not who we're talking about here. We're talking about someone who eats out for all meals of the day. So do keep in mind that when we're thinking about increasing our fiber intake, if we choose to engage in like supplementation, like Metamucil here as an example, careful with that because that can alter, if you have a prescription medication, it alters absorption of the drug. So just keep that in mind. Okay, so how do we screen for these folks? Well, it's exactly what you'd think. Rectal bleeding can be an issue, and pain in the area in which the GI tract is located. So the abdomen, pelvic region, your back, and your sacral region. A lot of times this comes in tandem with a vague cramping pain to the abdomen and a palpable abdominal mass. Can't tell you how many times patients have explained that away, like they're telling me their story of diagnosis, and there was a mass, and they tried to find a reason that it wasn't a problem. Again, the self-denial is real. That's just a human psychological phenomenon here, okay? Back pain with this population can radiate down the lower extremities. It tends to be bilateral, by the way. If they have an issue with hemorrhoids, that's often a factor as well. They may have anemia, so that's from the bleeds, right? As well as like absorption's not happening perfectly well. So they might have some increased fatigue or shortness of breath. Stools here can run the spectrum. So you can have tarry stools, so that means that there's probably a bleeding source in the upper GI, such as esophagus or stomach. But if there's bright red stools, that's bleeding in the lower GI, such as down in the colon. So the body doesn't have time to try and break it apart and make that blood color look darker. So bright red blood in stools, bleeding in the lower GI. It's pretty dangerous. And then this rather unusual phenomenon of having stool that's very thin, we're talking pencil thin, that's often an indicator of colorectal cancer, specifically in the rectum. So PT implications here. Well, things to keep in mind, sometimes individuals have issues with another organ, but the source is actually from the rectum. So if somebody has issues with the prostate or the vagina, actually the source can be a tumor of the rectum. So that's something to keep in mind in terms of screening if you're working with populations in that area, which is mostly going to be a pelvic floor therapist. A lot of times, if this is spreading, you can have kind of this strange, dull, aching pain. So for those of you who are planning to work in outpatient ortho, this is another worst case scenario, 1 in a million type thing, in which a patient presents with back pain that is actually colorectal carcinoma. So that's going to be a sacral and lumbar spine region. Once again, anytime somebody also presents with low back pain and then at the same time has an abdominal pain that's at the exact same level, and maybe that abdominal pain kind of comes and goes, nope, refer that right back. That seems simple, but it's actually quite serious. That's often a screening type attribute for colorectal carcinoma that hasn't been caught yet. So with all these conditions, whether they actively have the diagnosis or they're in recovery or anything like that, you definitely want to know a local pelvic floor therapist. That WCS That's the abbreviation for those who are board certified pelvic floor therapists. So keeping that in mind, yeah? Okay, another serious one, appendicitis. You might know somebody who's had this. Maybe you've had it yourself, because the most common population who gets it is individuals in their 20s and 30s. So for whatever reason, it skews more male than female. And what's strange is that given the etiology, not really sure why it has a bit more of a presentation demographically in men more than women. But what ends up happening is that sometimes you get an infection in the vestigial organ of the appendix, and it gets obstructed. And when that happens, you get bacteria buildup and backup. So that's why it's so dangerous and why they have to remove the little inflamed appendix. The surgery is, of course, called an appendectomy. If it's caught really quick, this is going to go fine. So once it starts, once the inflammation starts, the clot kind of starts. So if it's caught within 24 to 48 hours, recovery and prognosis are actually excellent. The problem is when it doesn't get caught in time. That's usually what happens. This is, again, another explain it away thing. You may notice that that's a psychological trend in anything, but it's particularly notable, I would say, in conditions of the GI tract. So if it ruptures, we sometimes call it a perforated appendix, then you can have contents of the appendix spill everywhere, and you can end up with an abscess or sepsis, and that complicates things. So if you have somebody who's unfortunate enough to have experienced this, the odds are good that they can have recurrence of this, which is kind of strange. So they need to be aware of the signs and symptoms. Let's dig into that. Okay, so the classic, the iconic right lower quadrant abdominal pain. It is specific. Now, every once in a blue moon, somebody wants to tell a story about somebody who has flipped organs, but we're not worried about that, okay? It is right lower quadrant pain. So right around the right anterior iliac fossa. The classic site that we palpate is called McBurney's point, and we'll go ahead and practice this in class, but if you want to do it right now, okay, take your left hand and find your belly button or your umbilicus. Take your right hand and find your right ASIS. Look down and note the angle those are making. Take your left hand and make kind of put it on that diagonal line, heading from the heel of your hand being at your umbilicus, and maybe your middle finger, index finger coming towards the ASIS. That's the straight line that you're doing there. Now along that line, go to your ASIS and come up maybe, 1.5 inches, 2 inches on that diagonal line. Take your right hand, take your middle finger and put it at that spot you've identified, that's 1.5 to 2 inches from your ASIS, and drive it down. You've just done a check of rebound tenderness for McBurney's point, okay? That's the classic. You can also do psoas sign. You lay the person in supine, dangle the right leg off of the plinth, and passively extend that right leg, and they end up with right lower quadrant pain. Mind you, it's going to be exquisite. They're going to yelp. They probably won't even let you extend the hip. That's psoas sign. Both of those basically are looking for irritation in the right lower quadrant. And McBurney's point is, in theory, where the appendix is located. So tenderness in the right lower quadrant, or pain, and I mean pain, 8, 9, 10. 10 is not unusual. Accompanied with nausea and vomiting and a very low-grade fever. So if it's gotten worse, we're further into the 48-hour clock, the fever tends to get higher, but it usually starts really low. And then in women, this can present as kind of a vague acute pelvic pain. So again, noting that McBurney's point, right? It's right off the ASIS just a little bit, which makes sense anatomically. You can see where the appendix is. And then that classic scar. So this individual in the lower right image has more of a longer scar. They must have had to go in and do a little more work, because usually they can go in and do the smaller little 1 inch to ½ inch scars with a laparoscopic little small removal. They can go in and just scope it all out. They also tend to try to make one of the scars near the umbilicus these days, and they try to get things that are kind of lower so the individual, again, this is in younger folks, they tend to want to, not wear a shirt, so to go swimming and whatnot. So they try to make it so that it's cosmetically a little more doable. Okay, so clinical pearl I would say here is that this region to have discomfort in that right lower quadrant, for an individual with a menstrual cycle, honestly, menstrual cycle pain, especially individuals with more complex menstrual cycle presentation, it can be hard to tell if that's what's going on, especially if an individual happens to be having their menstrual cycle and it's the right ovary's turn to drop an egg that month. Yeah, that pain can be too vague. And in addition, when folks are communicating pain, especially visceral pain, they're not very good at nuance. Like everything just kind of hurts, right? It's hard to distinguish ache from soreness and stuff like that. It's all just pain. So McBurney's point is really important, but it's not the end-all be-all. You need to take the constellation of the patient's presentation. So in other words, the nausea, the vomiting, the fever, things like that, to kind of get to okay, I think this really is happening. So appendicitis in PTs, we're looking out for it. That's basically it. So right thigh pain, right groin pain, right testicular pain, right pelvic pain, referred pain into the hip, all of that, you kind of want to screen, especially with the presentation and age in combination, okay? So epidemiology matched with clinical presentation, that matters here. In addition, we have a little bit of an age deviation. So in an elderly patient, it's not super common to happen in elderly folks, but you don't want to miss it, okay, especially if you're working in a nursing home. So in this person, an elderly patient with appendicitis, it's usually a lot more vague and the pain is lower. There's often only a slight elevation in body temperature. So basically, if someone's a little older, has vague right lower quadrant pain and a slight increase, nope, send that back. So that's something to keep in mind. When we get to class, I'll tell you about my friend who had it. Basically, it wasn't as dramatic as I thought it would be. He honestly thought he just had a GI bug, and he threw up a couple times, and then in the night, the presentation happened. So I'll tell you more about that as we go in. Hospital side, the big thing here is that you're probably going to see the folks who rupture. So if they don't get in time and the appendix does rupture, you end up with a surgical procedure called a peritoneal or an abdominal washout. Let's take a look at that a little bit here. Okay, so this is an open abdominal surgery where they have to go in and clean everything out. They can do a laparoscopic version of this, and that's where they use more for diagnostic proceedings. So that's like they think you have some sort of cancer of that lower viscera, and they actually like fill you full of fluid, wipe it all out, and then from the fluid that they've like extracted from you, they look for cancerous cells. They can also sometimes do this if they're worried you have some sort of occult infection that they're not finding. But for the most part, when we're thinking about a burst appendix, we're thinking about the open abdominal kind, not the laparoscopic kind where they make smaller incisions. And in this kind, they're going to go in, perform any needed surgical repairs, and then they're going to flush all of your viscera with saline to try and get all the possible infectious agents out and keep you from going like fully septic, and then they're going to close you up. They might close you up with stables, they might close you up with a wound vac. So this top image here labeled E, I pulled this off of a paper that had a lot of examples of what it looks like after a peritoneal washout and how to close people up. So if you're interested and you want to see some really righteous surgical images of viscera and organs like in open air, feel free to pull that paper. Otherwise, maybe don't, because you'll see a lot of intestines. So like I was saying, this one up here, this is from a perforated appendix. This one's from a gunshot wound to the abdomen. So this individual also needed, surgical repairs. Then they had to flush them and then, close them back up as best they could. And so that's why this person got packed and has a wound vac. So with these peritoneal washouts, just as like it makes sense. They're in extraordinary levels of pain. I truly hope I never, ever need a peritoneal washout. But what's really wild for us as PTs, they really, really need to get up. Like, oh my gosh, we'll talk more about it during class, but these ones, you're going to need to lovingly pull out of bed, and they will not want to, which makes sense given the pain they're going to be in. We'll talk more about this in class. Okay, let's talk about another one that also goes under the radar, diverticulosis. Okay, so when you're talking the lower intestinal tracts, if you get, over time, small bulging pouches that aren't supposed to be there, so see the Mickey Mouse ears here? The ears aren't supposed to be there, okay? The face or the head of the Mickey Mouse here, that's the intestinal, the course of the intestines there. So the ears, yeah, we don't want that. Individually, each of those is called a diverticula. So when those get irritated, we end up with more things happening. But the formation of the Mickey Mouse ears in general is diverticulosis, okay? So the little pouch shouldn't exist. And honestly, half of your geriatric patients have it. They think it's from inadequate fiber intake, honestly, as well as other dietary things. And if you just have the diverticulosis, the losis condition, it's not unusual for patients to have issues with cramping, like abdominal cramping, bloating, and issues with constipation. And guess what? They have constipation, so they bear down, and they can often make the condition even worse. Now, if one of those little pouches gets infected or has something go wrong with it, then it might get inflamed or rupture. Just the inflammation alone is due to microperforation. In other words, it breaks just a little bit, as you can see in this little image right here where it opens up. So that is diverticulitis. And that's often from an infectious source. And again, it skews different directions. So this is kind of interesting. So the infectious etiology or the ruptured etiology actually skews a little bit younger in men and older in women. So we do want to be aware of that because that's part of our good screening. This can end up putting you in the hospital. If you have a rupture of one of the diverticula, you can end up with a condition called a fistula. So fistulization to an adjacent organ, in this image here, basically that means the contents of your intestine are ending up in the bladder instead. Yeah, that's a medical emergency. So we want to be aware of our age breakdown. Epidemiology matters here, right? With it skewing a bit younger in men and a bit older in women, but in general is present in over half of our gerries, okay? So again, we really want to catch this early because fistulas are really dangerous, right? It's a normal connection between two body organs usually, and it's almost always like a tube with something going where it's not supposed to. So in other words, they're going to have fecal matter coming out of their bladder in this example here in the image. So yes, that's terrifying. Okay, so how do they look when they have the diverticulitis, the itis condition, not the losis, the litis, okay? So in this itis condition, nausea, vomiting, diarrhea, or constipation, depending, abdominal pain to either lower quadrant, right or left, fever. They're quite tender to palpation. I mean, they're going to be, oh gosh, so we call it peritoneal signs. That's rigidity, guarding, and rebound tenderness. It feels like if somebody were to put a book underneath their shirt and tell you to try to palpate. That's the level of rigidity you're going to feel to the abdomen, okay? It will not give at all. So just kind of something to keep in mind with this condition. Risk factors, exactly what you'd think. A diet low in fiber, high in fats and red meats, a medical history of obesity, smoking, and then also sometimes as present individuals who take a lot of NSAIDs or they've been on long-term steroids or opiates, okay? So unfortunately, this happens in our patients who are trying to achieve some level of pain management. What do? Antibiotics to try and clear out the infection. They rest the bowels. They try to flush you out. So they do, not the open surgical type of flush out, but with trying to give you a lot of saline. And they might have to go in and do surgical repair, especially if the bowel has torn, and so that'd be a perforation. Also, they might need to go in and repair fistulas. They don't always, that's a surgeon's decision. We just interact with it as it goes. Gastroparesis. I have this one here because we just talked about diverticulitis, and that's sometimes a condition which can occur in our folks with issues with opiate use. One of the most common and frustrating side effects of opiate use is a condition called gastroparesis, in which peristalsis does not occur to the intestines. In other words, everything just stays put. So you don't have emptying and you basically get an obstruction. A small bowel obstruction can put you in the hospital with great ease. It seems simple, but it's quite serious, right? So how are they going to look? A lot of bloating, nausea, vomiting, and they get full really quickly. So unfortunately, when it comes to gastroparesis, a lot of times we don't know what causes it. It's idiopathic. Sometimes there's a diabetes complication. Honestly, a lot of what you'll see in the hospital is post-surgical. They've had a surgery for something else, and they're taking opioids to manage that acute surgical pain, and they end up with secondary gastroparesis from the opioids. It's really frustrating. Then what's really nice for SPTs, though, is that by and large, gentle walking helps get the guts moving again. So it resolves the peristalsis paresis state. There's now some debate in the literature over, the whole logic of gentle walking to get the guts moving again. But I got to be honest, this is just a Liz stats. I'm really not here for that. I would say the gentle walking helps upwards of 2/3 of my folks with gastroparesis. That's just Liz stats. That's not real science, but that's pretty good outcomes for not that much movement. In other words, it's probably worth a try. And good news is it doesn't really cost you anything. So abdominal aortic aneurysm. Okay, last one here. This is not a GI condition, but by convention, we teach it during GI content because it's in the same anatomic region. You're already thinking about that part of the body. So what happens is that you have the abdominal aorta, and in this condition, you have a massive swelling or an aneurysm of that structure. So sometimes this is found on accident. A person's having a scan, and the classic is they're having a scan of their discs of their back or something intestinal related, and this gets caught at the same time. Or it gets caught terrifyingly once it ruptures. Rupture is absolutely life-threatening. So what makes people inclined to have risk for this developing? Advanced age, unfortunately, is a big factor. Tobacco use and atherosclerosis are in the mix too. It's much more common in men than it is in women. And of the particular, if I were really getting down to it, it would be an older white male with a history of smoking. Otherwise, though, I don't think I've seen it ever in anyone who's younger than in their 70s. So my experience matches with what the literature tells us. It's a condition for older folks. So 2 presentations here that we need to be worried about. One is the non-ruptured status, which, hopefully is the only thing that you see. And this is an abdominal mass, which is not tender, but pulsates. In other words, you put your hand on their stomach, just south of the belly button most of the time, and push in a little bit, and you'll feel a throbbing. And so that's the heartbeat, right? So that's a pulsatile abdominal mass, and it doesn't hurt them to palpate it. If it's getting bigger, if the aneurysm is enlarging, then the pain pattern may change, and it can refer into the abdomen, into their flanks, or into the back. Now, if they get to a point where they can't tolerate a little bit of squish on the abdomen, and it's diffuse pain everywhere, and it's kind of expanding out, and now it's painful over the site of aneurysm, they're likely either at or about to be at a ruptured status, and that is such a hard red flag, I can't even find the words. So, one time I had a patient who had a stable AAA, and I didn't want to palpate her stomach because I was concerned to cause her distress. I just figured it was tender, even if it was in a stable status. And I told her, yeah, I don't think we want to palpate. And she goes, oh, really? My vascular doc always palpates it. I said, yeah, I'll leave that for them. If they say it's stable, I'm comfortable with that. I was a little newer in my career. And she took my hand without, my asking, and put it over her abdomen, took her hand on top of it and squished it in so that I felt. And sure enough, it's pulsatile. And I was like, oh, and this isn't causing you, any distress? And she goes, not other than you squishing. It doesn't hurt. And I said, okay. So there you go. It shouldn't hurt. I wasn't really looking for that experience, but there you go. Patience, right? What are you going to do? Okay, so prognosis here. Okay, so if it does rupture, it's flip a coin on if they make it to the emergency room. Yes, that's how serious it is. So the good news is that if it's pre-rupture and they say, okay, you know what, I get it, this is dangerous, I'm going to go ahead and do elective repair. An elective is really just a phrase they use in surgery, which basically means you still have the capacity to make a decision on whether or not to go through surgery. Prognosis is actually excellent. This goes pretty well. In fact, their survival after repair depends more on other comorbidities. So if they have COPD, heart disease, or peripheral vascular disease of some kind, that's more of a concern. So that's why I say, yeah, you want to consider it, because if you get away the rupture, your odds are actually much, much lower than if you opt for the surgery. So I've got a slide here just to give you a sense, because you might be thinking, oh my gosh, I don't know if I want to work with somebody even with a stable AAA. Turns out it's actually a version of okay. It's managed risk, let's be honest, and you need clearance from the physician. So I've got some papers and some information here, but I got the take-home message here. So long as their vascular doc or their cardiologist clears them, you can work with them. You just need to know your red flags and be really careful. Just need to know that it's stable. Okay, and I've got one more slide here because when we're talking about GI symptoms, they're so vague, but just reiterating, if you have a patient with some of these things happening, you want to screen, just see what's going on. There's a lot of really pointed questions you can ask regarding, bowel and bladder movements or bladder function and whether or not they're having any vomiting and stuff like that. And you'd be surprised often a patient's like, oh yeah, sometimes I vomit and there's a little bit of blood, and they haven't offered you that information default. That happens sometimes, and we want to chase that knowledge and make, good on the fact that they came to see us by referring appropriately. All right, team, I'll see you in class.